Thanks so much, Dave, for inviting me. So again, we'll spend about the next 20 minutes talking about adjuvant therapy for biliary cancer. It's always interesting to be invited to give a talk when there are almost no clear data. So hard to be wrong here, but we'll do what we can. Okay, so this is the summary for where I'd like to go with this talk. First, I think we'll sort of step back historically and talk about some of the models and meta-analyses which have been done, which have guided our therapy in the absence of clear randomized data. We'll then talk about a couple of trials that have happened and focus particularly on SWOG 0809, which is actually in press now in JCO, which I think will help us to guide future clinical trial information. We'll talk a little bit about which chemotherapies to use because it comes up a lot. And finally, because there's no advanced biliary cancer discussion in this session, I thought we should talk a little bit about some new targets that are very promising. I think they will make their way to the adjuvant setting, at least some of them will, but I think they're interesting stories and they deserve a little bit of comment. Finally, we'll go through the NCCN guidelines to help you answer your questions, some of the questions that Dave has given, and also tell you how I treat these patients. So I want to keep this very practical and happy to answer any questions at the end. So as you know, there is both anatomic and molecular heterogeneity for biliary cancers. Because these tumors are so rare, they're often lumped together. And I put on the left just a slide so you know where the intra and extrahepatic boundaries are. But remember, also, there is a lot of molecular heterogeneity. So for instance, we know that KRAS mutations are much more common in intrahepatic biliary cancers, for instance, whereas ERBB2, HER2 amplification and overexpression is much more common in gallbladder cancers. So that will have implications for how we treat patients moving forward. So I think the first paper that really kind of changed the way that we think about practicing for patients with predominantly for gallbladder cancer was a paper that came out in JCO in 2011. So this was actually a study done by radiation oncologists from OHSU, so in Portland. They took about 1,100 patients from the SEER Medicare database and put them into different algorithms to try to figure out best treatment scenarios for different stages of patients. And what they found was that for all of the sub-cohorts of patients, chemoradiation seemed to work better than chemotherapy alone for everybody, but particularly for more advanced patients, so those that were T2 or those that were node positive. So some caveats to the database. So in SEER, margin status is not reported, performance status is not reported. And I think most importantly, this data set only had about 6 to 7% of patients who underwent radical re-resection. And we'll talk about that a little bit more at the end. This is a really, really important point. I think the main take-home message for gallbladder cancer patients. So if you have a T1b lesion or greater, that means into the muscularis, the tumor's going into the muscularis, you have to send them back to Dr. Choti, back to your surgeon, so that they can re-resect your lesion. And I'm sure he can describe it better than I can, but you take a rim of liver, usually at least 2 centimeters, and you dissect out the nodal basin. And I'll show you some data that this is very, very important. So because they were not able to control for that, I think that this is a big limitation to their data set. Okay, nonetheless, they made a very nice nomogram that you can use to plug in features of your patient, and it will give you basically outcomes with surgery alone, surgery plus chemotherapy, and surgery plus chemo-RT. And again, if you do play with this nomogram a little bit, you'll see that most people do the best with chemo-RT, interestingly. So the next year, Jennifer Knox and her colleagues at Toronto basically reported a large meta-analysis and pooled conglomeration of basically the biggest 20 studies that had been done, all in the English language. So this was really a gamish of different types of treatments. There were 3 studies that were chemotherapy alone. There were 2 registry studies, and the rest were pretty equally mixed between radiation alone and chemo-RT. And so what they did was they basically looked at everybody who got some sort of treatment compared to the people who got surgery alone. And what they found was that there was a non-statistically significant but very close improvement in survival with those who got treated. The p-value was 0.06, so just missed. What they found were that in pre-specified subset analyses for node-positive patients and for margin-positive patients, these did become significant. So it looks like the benefit is for those in more advanced patients. Interestingly also, chemotherapy and chemoradiotherapy seem to be statistically better than radiation alone. And when they divided out the people who were margin positive, they were the ones that had some benefit from radiation. And interestingly, the people who were margin negative, if they got radiation, there was actually a non-statistically significant trend towards harm. So that's kind of where we were, I think, in terms of treating patients with biliary cancers. And I think another limitation to Jen Knox's analysis is there was only one study with intrahepatic cholangiocarcinomas, and the vast majority of patients on these trials were biliary cancer, so extrahepatic bile duct cancers. So I'll show you a little bit of data. So this is the forest plot, basically showing the breakdown. These are the gallbladder cancer patients. These are the cholangios. Neither were statistically significant. And here's the overall, sort of hazard ratios. Actually, they used odds ratios in this study, not quite statistically significant. Again, if you look at the node-positive disease, the forest plot diamonds shift to the left, suggesting greater benefit. And again, for margin-positive disease, they shift even a little bit more, suggesting actually this is the patient population that gets the most benefit from any sort of adjuvant treatment. So how do we make sort of, what do we do with these two very different analyses? So I think it depends on whom you ask. Also, these are two different patient populations. Interestingly, in the Knox meta-analysis, where this was run by medical oncologists, chemotherapy looked better. And in the chemo-RT analysis, that was run by radiation oncologists, chemo-RT looked better. So convenient, I guess. I think the biggest differences, again, were that in the Serum Medicare analysis, because there were so few people who got radical resections, I think the radiation actually made up for those people not getting adequate surgery. I think there were different types of chemo. So again, the Serum Medicare analysis was a little bit older. Almost all of those people got 5-FU. We don't know if that would have made a difference or not. And also, we know there's better recording of data in Jen Knox's meta-analysis, because in Serum Medicare, if you get chemotherapy someplace else, like at a VA, your chemotherapy is not recorded well. So I think for all of those reasons, you can kind of explain the differences. So again, that is sort of where we were. There are lots and lots of smaller studies. I thought it would be easier just to go through the big papers rather than go through all of the little studies individually. So what do we do now in terms of clinical trials? So we have no large randomized trials that have reported out yet. There's one small trial that I'll mention briefly just because it's always quoted. And I'll mention in a little bit more detail SWOG 0809, which is an intergroup phase 2, as I said, that's pending now in JCO. So the randomized trial was from Japan. It was about 500 patients, and it included everybody. So it included pancreases, it included gallbladders, biliaries, and also ampullaries, which are not usually included in most biliary cohorts because their prognosis is so much better. They gave sort of old school chemotherapy, 5-FU and mitomycin C, and they gave it atypically. So they actually gave a dose of mitomycin the same day that the patient was going to the OR. Then they gave 5-FU IV, sort of weekly, weeks 1 and 3, and then they gave oral 5-FU until the people actually recurred. And what they found was that when they looked at everybody who got treated, the only patient subgroup who benefited were the gallbladder patients. But when they looked for intention to treat, actually that lost statistical significance. Interestingly, also, the benefit was seen only for those patients who underwent non-curative gallbladder resections. So you wonder, were these really adjuvant patients at all? Because it's always shown, I'll show you the hazard, the Kaplan-Meier curves. You can see here, again, it looks like there is a trend towards benefit for gemcitabine. The way they had done the statistics, they needed to have 60 patients in each arm to show a 5-year improvement, 20% improvement in 5-year survival. So you can see this is underpowered in the control arm when they ultimately looked at the intention to treat analysis. So a poor quality study, but the only randomized study that is really out there. So I think we should spend a little bit more time on 0809. So again, this is an intergroup phase 2 single-arm study for high-risk patients with extrahepatic biliary cancer and also gallbladder cancer. So you had to have some sort of high-risk feature. So either T2 or greater disease, you had to have nodal positivity, or you had to have positive margins. So then we gave 4 cycles of chemo, and the chemo regimen that we chose to use actually was GEM-CAPE, because this was done before the GEM-CIS data were available. And after that, people were then given concurrent capecitabine with external beam radiation. So the statistical plan was that with 80 patients, we would be able to show a 2-year survival of greater than 45%. And if we were able to do that, that would be considered promising. And there was a planned subset analysis to look at the R0 and R1 cohorts separately, so those, the margin positives and the margin negatives. So this is table 1. It's a little bit small, and actually, so you can basically see that for our patients who were R1, the positive margin patients, they were a little bit, they tended to be actually a little bit younger. They tended to be more likely to have bile duct cancer. They had a slightly worse performance status, and they had a slightly higher CA19-9. These were the results in a nutshell. So we greatly sort of succeeded our expectations for 2-year overall survival. The overall survival was actually 65% overall, and median overall survival 35 months, which was much, much higher than we had anticipated. So of the 79 patients who were eligible, 54 were R0s, 25 were R1s. Most of them had extrahepatic disease rather than gallbladder disease. And treatment was really well tolerated. So 86% of people completed treatment. The grade 3-4 toxicities that we saw included some neutropenia, some hand-foot syndrome, a little bit of diarrhea, and one person died of a duodenal bleed. We weren't sure if that was related to treatment or not. So this is the overall survival Kaplan-Meier curve. You can see, again, 65%, really, really much better than expected. And I think also something that we didn't expect was that the R1 and the R0 cohorts did very, very similarly. You can see here that the people who had clean margins did a little bit better, 67% 2-year survival, versus 60% for those who had a positive margin. But we were expecting a much bigger difference here, and that was a little bit of a surprise. So also in terms of site of recurrence, you know, the common lore, and there's a big paper from Memorial suggesting that gallbladder cancer patients typically present with metastatic disease and have much lower rates of local recurrence. But here, we found really low rates of local recurrence pretty much for everybody. So here, these are for the extrahepatics both, and you know, none of the gallbladder cancers recurred, only locally. But even those with distant and local recurrence, it was much lower, again, than we expected. We expected about 30% local recurrence rate, particularly, and a little bit higher for the extrahepatics. So notable findings. I think this study really established the feasibility of doing a large intergroup study with a rare subtype of cancer. We did very careful central reviews of pathology, radiation oncology, and also the surgery plan. We found high rates of R0 resection, 68%, which we didn't really expect in such a large study. And really interestingly, I think the fact that the margin-positive patients did almost as well as the margin-negative patients, which really makes you wonder, is the radiation doing something? It's difficult to compare the biliary and gallbladder patients because they were not equally matched. So what is the adjuvant landscape now for biliary cancers? I think 0809 is an important study. I think we will use it to guide future therapy. There are several studies ongoing, mostly in Europe, asking the question of chemotherapy versus placebo alone. So very similar to pancreas cancer, where Europe usually does chemotherapy, and we're still concerned with radiation. There's a UK phase 3 study, it's called BILCAP, looking at capecitabine versus observation in gallbladder cancer, intrahepatic and extrahepatics. So here there is an intrahepatic component. It has completed accrual, and we are awaiting reporting. Similarly, there's a French phase 3 study of gem and oxaliplatin versus observation in gallbladder, intrahepatic, and extrahepatic disease. It's also completed accrual. We're hoping that that will report out very soon, maybe even at ASCO. And finally, there's a German phase 3 gem-cis versus observation study that started a little bit later. So we were trying to think of how we wanted to use 0809 to sort of plan the next step in therapy, and we decided to ask the radiation question. Good for us in the United States. So this is a planned phase 2-3 study of gem-cis. So we changed our background, our backbone, to gem-cis from gem-xylota based on the Valley data. And because we think probably the gem-oxaliplatin regimen from France will end up being a positive study. So we decided to basically test chemotherapy versus chemo-RT versus gem-cis alone. We're working on statistics for that, and hopefully we'll present that at the next intergroup meeting. So in terms of gem versus gem-cis, I get asked this a lot. I think you can also argue that xylota is a perfectly reasonable alternative, although it does tend to be more toxic. So in terms of the combination, the arguments are it's not that much more toxic, looks better in the advanced setting. I think to the points that were made about pancreas cancer, I would agree with doing gemcitabine alone until we have more data. I think, as was already discussed in colon cancer, more is not always better. Irinotecan actually may have a possible detriment. And there is a real possibility of toxicity with cisplatin. The Valley study, even in the advanced setting, showed increases in neutropenia and also increases in thrombosis. So one thing that I think that's not as commonly realized is very high rates of thrombosis with cis. There's actually a retrospective large review from Memorial showing that up to 18% of advanced patients who get cisplatin have some sort of a venous embolic event within 100 days of their chemotherapy. It's even higher in patients with pancreas and biliary cancer. It's 37 and 30% respectively. So I think without clear data, it probably makes sense to give single agent. So I wanted to talk quickly about potential targets for the future, not so much, again, for the adjuvant setting, although I think that some of them will get there, but because I think these are important stories. So these are the three that I'll mention very quickly. HER2 you know about, IDH1 and 2 you've probably heard about, and the FGFR2 story I think is evolving and also really interesting. So HER2/neu, as you know, it's an oncogene overexpressed in breast and gastric cancer, and now we're finding it's also overexpressed in up to 15% of gallbladder cancers. So we have our very large series of 8 gallbladder cancer patients together with MD Anderson. We gave them all Herceptin. Most of them also got Gemcis. And we actually saw 1 complete response and actually 4 PRs. So really pretty promising. We're trying to get together either a bucket trial or a larger prospective study going. It does raise the question, should we be trying this in the adjuvant setting for those who do overexpress, as we do in breast cancer? I would imagine that we would do this with a chemotherapy backbone. So the IDH pathway, also very, very exciting. You guys may have seen some of the data in leukemia. So basically, this is a gain of function mutation where alpha-ketoglutarate gets turned into 2-hydroxyglutarate, which in a nutshell, I think does 2 things to cancer cells. It causes a de-differentiation process, and it also causes hypermethylation at CpG islands. So for leukemia, you can imagine that this is a really important process. You want to, if you give a block to this, you can cause leukemia cells to differentiate. And in fact, really nice results we're seeing using these drugs in leukemia. I think in solid tumors, it's not totally clear how this will pan out. Differentiating a solid tumor is not clear if it will lead to shrinkage, and it's not clear if this will work in the adjuvant setting. Also begs the question of should we be giving these drugs with potentially demethylating agent? And there are really interesting data in brain tumors looking at IDH1 mutant patients who get decitabine with solid tumors that may actually show responses. So I think an interesting pathway to look at. Interestingly also, just to show the heterogeneity, these are really only seen in intrahepatic cholangiocarcinomas. These are data from MGH showing that IDH1 is here almost 12%, IDH2 lesser, but up to about 20% of people with intrahepatic cholangios have these mutations, and other types of biliary cancers really don't. So finally, I think the FGFR2 fusion story is another really interesting pathway. And I think all of these raise the question of molecular testing for your patients. So I hope that you guys are testing all of your biliary patients with Foundation 1 or some other genomic panel. So again, these are seen in intrahepatic cholangiocarcinomas. A Mount Sinai paper actually just reported out that about 45% of patients had one of several FGFR2 fusions. And you can see that they were not mutually exclusive. Initial paper had suggested that they were mutually exclusive with KRAS mutations. This one did not. And you can see here again that there is a drug that targets this mutation. There's one from Novartis. There are several others that look really promising. So another very interesting story. And I will finish up just to say for incidental gallbladder cancers, about 1% of people who have cholecystectomies have an incidental cancer found. Remember, if you have a T1B or greater tumor invading into the muscle, you send them back to your surgeon. And this is the reason why. Because this is what happens if you do a radical resection. This is your survival, and this is your survival if you don't. We know that this surgery type is extremely underused. Only about 12 to 15, 16% of patients actually get this in a recent SEER review. So these are the NCCN guidelines. I think for the sake of simplicity and because I'm running out of time, you have them in your handout. I would just make the point of considering re-resection here for anybody with margin-positive disease, if it's possible to do so. And I'll finish with what I do. So for gallbladder cancers with T1B or greater disease, I go back to the surgeon and say, you guys need to re-resect this person. For a T2 patient or node positive, I give 6 months of GEM. For R1s, I try to resect or give chemo-RT and then GEM. For extrahepatics with clean margins, I give 6 months of GEM. For R1s, I consider re-resection or give chemo-RT followed by GEM. And for intrahepatics, very little data. I usually give 6 months of GEM. If it's R1, I try 2 months of GEM, re-evaluate them. If they've regenerated their liver, send them back to the surgeon, see if they can be re-resected. If not, then I will give them radiation. And for R2s, actually, so gross residual disease, there's actually a recommendation to give Gemcis, because they are patients that are included in the Valley study. So this is Central Park. This is what I hoped Central Park was going to look like for you guys today, but unfortunately it's a few weeks away. I hope this is also our path to better studies and better answers for biliary cancer. Thanks.